Hi, my name is Dr. Aston Goldsworthy, and today I'm going to talk to you about how chronic migraines could be caused by a postural issue. So posture, we know all of us have terrible posture to some degree. We catch ourselves every day probably hunched over the computer, on our phones, doing all sorts of various things. But before we get really into how posture can cause chronic migraines, let's talk about symptom-based care versus functional-based care. So in a disease model, we have the beginning of the disease and then we have the end of it. Typically, in a disease model, you're going to see a loss of function somewhere in the beginning. And then you'll see symptoms about halfway through, if not further, in the disease process. Symptoms in this case would be headaches, migraines, neck pain, those different things. And then you have the end of the disease process. And so in a symptom-based care model, we're going to utilize medications that mask symptoms. So things like triptans, Topamax, beta blockers, over-the-counter medications. All these things have to typically be taken for the rest of that patient's life because it's a chronic condition. So these medications are either taken on a daily basis or for abortive reasons. In a posture or in a functional-based model, what we're going to look at is the actual function or the mechanics that could lead up to this chronic migraine. And so what that brings us to is typically a postural situation. And so the neck is not designed to elongate past the rest of the spine. So when the neck starts to drop forward and the shoulders roll, we usually have an over-tightening of several different muscle groups. So the muscles that typically would hold your head and neck up here, these postural muscles, they're unable to do that when the head is elongated out. It's kind of like taking a bowling ball and holding it here or trying to hold it out here. You can't quite hold it out here as long. So these muscles get overworked and they actually require the recruitment of large muscle groups, which are phasic muscles. Now, phasic muscles are designed to move you. They're not designed to hold you in place or sustain contraction. So when muscles that are designed to move you have to sustain contraction, they're going to tighten. And when they tighten, they restrict range of motion. One of the things we see is a lot of these muscles connect at the base of the skull. And right there at the base of the skull, we have what we call the occipital nerve. And the occipital nerve runs around this side here and usually back behind the eye or into the forehead area, and so patients will start to get headaches in that referral pattern. Usually they'll start with neck soreness and lead into that type of pain. Other things that we see due to postural changes, such as shoulders rolling forward, is now this is a drawing of the back. So these are scapulas, this is collarbone, skull, neck. Okay, I'm not an artist, but what you'll see is the muscles that connect to the scapulas start to bundle up or develop what we call trigger points. Now, trigger points are those spots where you push on them and they feel kind of good, you know, it's like, oh, it's a good hurt, or they kind of refer pain and they can be very sensitive and tender. But what a trigger point is muscles that have bundled up, and when those muscles bundle up, they become less elastic. So that means they don't move as well. So then, consequently, they're going to affect the movement of any bone they connect to. For example, the scapulas. If the rhomboids develop trigger points, it's going to affect how the scapulas move. But it's also going to affect these other muscles that move the scapula, which basically control your entire shoulder. So, for example, your levator scaps and your trapezius muscle are going to have to work harder to pull against these rhomboids, as well as the infraspinatus, which connects here too. So, if those muscles are having to work harder, they're going to affect how these scapulas glide, which is consequently going to affect these muscles up here and how they tighten around the neck. And so typically these trigger points will need to be treated in order to get even movement in the scapulas. Because when we have asymmetrical movement, we develop a condition called scapular dyskinesia. And scapular dyskinesia is a sign that there is some sort of trauma or dysfunction in the muscles that connect to the scapula. So what is the treatment options for something like this? Well, there's not just one treatment to treat this. I mean, usually this is taken an accumulation of years to develop. And so there needs to be multiple things addressed to treat it. So typically a functional-based PT program is going to be utilized, something to increase flexibility, retrain posture, cervical traction, things like that to treat this. Also chiropractic care, mobilization of the cervical spine, mobilization of the thoracic spine, to make sure that the spine itself is moving correctly, so that way the muscles that connect to it are able to function the way they're supposed to. Typically we'll use trigger point injections, which is basically a lidocaine saline solution, where we're actually pushing fluid into the muscle and displacing it from the inside out. So it's not really the medicine, because it's not really medicine, saline solution and lidocaine. It's the physical displacement of that tissue, so it breaks up that adhesion or scar tissue, which will allow these scapulas to move correctly, or anywhere you have a trigger point for that matter, for that area to function the way it's designed to. Another thing that we utilize is bracing. So When it comes to kyphosis or shoulders rolling, typically it's going to take a lot of physical therapy to pull that back up. But in the short game, you can use something like a posture brace or a TSO that will actually pull those patients' shoulders back. And we have a brace that's designed for correction, not just so much support. And it's shown that patients that wear this for 2 hours a day for a year change almost 20 degrees in kyphotic curvature, which is huge. And then the last thing that we utilize in patients, if all of this doesn't alleviate the symptoms enough for the migraine, is we use Botox. Botox for migraines is very effective. Basically, the Botox is injected into several locations into nerve fibers that typically, when they fire, they set off the trigeminal nerve and cause that migraine. So a combination of care that works together in synergy is the ideal way to treat a chronic migraine. With our patients, we see anywhere from 80% to 100% reduction in their migraines, after their treatment program. So if you have any questions or you know anybody that could benefit from this type of treatment, or you yourself, please check us out at coremedcenter.com, and thank you very much for watching.